If you have multiple sclerosis and your doctor's ever suggested that Ocrevus might be right for you, or if you've ever considered it personally, stay tuned. We're going to walk through how you can go about doing some research by yourself to better understand whether or not Ocrevus is right for you. So we're going to start off from ground zero, as you can see on my screen. This is exactly how you can do it for yourself. So to start off, we'll go to good old Google, and we'll type in the drug name. Now at the top, you'll see some ads here, but you can run down to kind of ocrevus.com, open this up, and the key piece of information that we're looking for is here, which is the prescribing information. The prescribing information tells you and doctors and healthcare and other healthcare providers exactly what is true and factual about a particular drug. And by reviewing this information, you can do a lot to make yourself a very highly educated patient that can make better informed decisions about your own care. So taking a step back, as you can see on my screen, we're going to start off by reviewing what's called the highlights at the top of the page. This is kind of like an outline. If you don't have much time to review this information, you can start here. It tells you very basic information about the drug. The first thing to notice here is that at the top left, here we have Ocrevus, and right next to it is, in parentheses, is the generic name of the drug, so ocrelizumab. We can also find some other information about the drug, which is it was first approved in the United States in 2017. We're now sitting here in 2023, so it's been on the market for 6 years. So as a commercial drug that's been available and been able to prescribe by drugs across or by providers across the United States, it's been that case for 6 years. So a lot of doctors will have a relatively long track record for prescribing this drug. It's not to say that 6 years is an incredible period of time, especially given that Ocrevus is a therapy that one could reasonably predict you might be taking for the rest of your life, but it is a reasonable length track record to understand the safety and efficacy of a particular product. So the next thing we're going to look at is what's labeled here as the indications used for this drug. Listed here, it says Ocrevus is a CD20-directed cytolytic antibody indicated for the treatment of, and we have 2 bullets, relapsing forms of multiple sclerosis to include clinically isolated syndrome or relapsing remitting disease and active secondary progressive disease in adults, 1. And then the second bullet here is primary progressive MS in adults. You'll notice these parentheses here as we go through the highlights of the prescribing information, and those actually correspond to the table of contents down here. So if you want to find out more about the indication statement here, that's in section 1. So you go down here, section 1, and then you can further move forward in the document to get additional detail for any particular aspect that you're looking into. The next section here is on dosage and administration of the drug. You'll see, I know this is a topic for a lot of multiple sclerosis patients, is pre-medication and why you might want to do that. Here you can see just at a high level, they recommend pre-medicating with methylprednisone or an equivalent corticosteroid and an antihistamine. They don't actually specify which one, but they just happen to suggest one. So there's some flexibility over what you might tolerate and what you might prefer with your provider. So it seems from looking at this piece of information in the and then if you want additional detail, then like I said before, you can follow down to section 2.2 as it's said here on the prescribing information. Also, if you've never taken Ocrevus before, there is, I would say, a loading dose or a starting dose where they recommend that you get 300 milligrams IV initially, and then 2 weeks later you get another 300 mg. So you actually get your first dose split out over 2 different trips to your provider. And then subsequently, you get a full dose IV once every 6 months. Scrolling through here to see if there's any other interesting highlights. We can go into this a little bit more detail. I know a hot button issue for a lot of people with MS is progressive multifocal leukoencephalopathy, or PML. PML is kind of beyond the scope of today's conversation, but if you want to find out more about the risks of PML associated with Ocrevus, the best place to go is section 5.3 here. So let's go into kind of the details. So the first thing that you need to know is once you get to the table of contents, if you're doing a similar analysis on any drug that's approved in the United States or it's been approved in the last 30 or 40 years, they're all going to have the same high level table of contents where section 14 is always going to summarize the clinical studies for a drug. Section 12 will always highlight the clinical pharmacology of a drug, and so forth and so on. So scrolling through here, we can focus on areas that might be most interesting to a particular patient who's considering starting this drug or a patient who's on this drug and wants to understand other aspects of taking this drug, such as pregnancy. So focusing here, let's move on to, I know adverse reactions and clinical trial experience is often a hot button topic as it speaks specifically to the drug's safety. So let's go down to Site 6. Adverse reactions. The following series of adverse reactions are discussed in greater detail in other sections of the labeling. Now we go down here, and you can get a little more additional detail if you want to go through warnings and precautions through here, but the adverse reaction section is really going to highlight what was seen in clinical trials. So we go to 6.1, which is the subset of section 6, and we can start reading. Because clinical trials are conducted under widely varying conditions, adverse reaction rates observed in clinical trials of a drug cannot be directly compared to the rates in clinical trials of another drug and may not reflect the rates observed in clinical practice. So this is kind of a cover-all, cover-your-butt statement, but it ostensibly says that the safety data shown here for Ocrevus may not be identical to what you see in real life, and furthermore, it can't necessarily be compared or contrasted to what you might see for another multiple sclerosis drug. And that's just a function of, I would say, how the clinical trials are managed and run. You're always going to have a different group of patients, and those patients are going to have varying susceptibility to adverse reactions from the drug. So let's go down to see what is happening in the clinical trials and what might be a reasonable expectation for what you might see in your personal life if you were to take Ocrevus. In active controlled clinical trials, study 1, study 2, 825 patients with RMS received Ocrevus, full dose, IV, every 24 weeks. 24 weeks is every 6 months. They did have the initial treatment regimen at weeks 0 and 2 as outlined up above in the highlights of the prescribing information. And then they looked over the course of 96 weeks. So you can see how down here, and this is where it's important to say where the cutoff is. And here you can see adverse reactions in adult patients with RMS with an incidence of at least 5%. So that means 5% of people. So if, for example, if 4 out of every 100 people had a type of adverse event, they would not be included here. This is below the threshold. So you only get on this list if you have more than a 5 in 100 chance of having that adverse event. So pretty rare. But you can also see what's most common here. Upper respiratory tract infections, 40% of patients. And this is also normalized. I'm just going to kind of caveat here. This is normalized to every 24 weeks. So it's not every year you have this rate. It's actually doesn't work out perfectly this way, but it's almost considered that you actually have twice that risk of having, because it's every 6-month interval, you have a 40% chance of having upper respiratory tract infection. Now, this trial that was shown here, there was an active comparator arm, which is Rebif, excuse me, which I believe is an interferon. Wasn't necessarily, there were almost similar rates of upper respiratory tract infections as you can see here. So 40% of patients treated with Ocrevus had upper respiratory tract infections, whereas 33%, which is kind of similar, on Rebif had similar type of infections. Moving down, infusion reactions, 3410. So this is maybe a little bit more significant of a difference between the two. This is, 3.4-fold greater infusion reactions with Ocrevus versus Rebeef, and we can talk about why that might happen. Similar rates of depression, similar rates of lower back pain, lower respiratory tract infections, all the way down. So not huge differences there. So that covers safety, and you can also see there was also a subsequent, there was a separate trial in primary progressive MS, and you can also see the incident rates of um, the different types of adverse reactions here in this trial versus the other trial. Now this has been an interesting development, which is there was also a new protocol for receiving infusions instead of over. It was originally Ocrevus was designed to be a 3.5-hour infusion. They were in a clinical trial showing that it was non-inferior to also in terms of adverse events um, for a 2-hour infusion versus 3.5-hour infusion. So looking back, that's almost half. It's probably 60% as long. You're able to have a similar type of severity. So let's go back to the top and see, we just talked about adverse events. What else might we want to look into to further understand whether or not Ocrevus is better, is a good option for us? Let's go to clinical studies. Maybe just to get things started, you can see that they have 3 different types of clinical studies here, listed here in each of the kind of the subsections of section 14. They have 14.1, which is for relapsing forms of MS, 14.2 for primary progressive multiple sclerosis, and then 14.3 for the safety study that I was just alluding to of 2-hour infusions versus 3.5. So let's go to 14.1 and get a better understanding of what that looks like. All right, section 14.1. And we can just start reading here. The efficacy of Ocrevus was determined in 2 randomized, double-blind, double-dummy, active comparator controlled clinical trials of identical design in patients with RMS treated for 96 weeks. So what does that mean? Randomized, double-blind, double-dummy, active comparator. So that's a lot going on, but you can keep reading to get a better understanding, and maybe we can stop after that. The dose of Ocrevus was 600 milligrams every 24 weeks. Initial treatment, as we talked about, it was completed per the highlights of the prescribing information that we already talked about, and placebo subcutaneous injections were given 3 times per week. That's in the Ocrevus arm. So, given that the dosing intervals are different for Rebeef versus Ocrevus, in order for the patients and their providers to be blinded towards who was getting Ocrevus versus who was getting Rebeef, everyone had to get the same number of shots. So even if you're on Rebeef, which is an injection of 3 times per week versus once every 6 months, all the patients in the trial needed to get ostensibly the same number of needles. So they needed to get 3 per week, and then they needed to go to an infusion center for their maintenance dose once every 6 months. So that way everyone was getting the same number of pokes, same number of needles, and they had no idea, so they were blinded. And that's where this comes back to. So patients were either randomized to one of 2 groups. It was either the Ocrevus group or the Rebeef group, but everyone was double blind. So double blind means the patient was blinded, and then also the provider that was delivering the drugs to the patient, they were also blinded. And double dummy, meaning that the Ocrevus group got dummy Rebeef injections, and then the Rebeef group had dummy Ocrevus injections. And then active comparator is because they didn't compare it to placebo, they actually compared it to Rebeef. So we can go through additional details here. I would say the important thing to keep in mind when reviewing clinical trials are understanding who was included in the trial and whether or not your current clinical presentation and your H&P corresponds to the clinical trial population. And if it doesn't, how close is it? So here we can understand a little bit more about what the trial enrolled. So both studies included patients who had experienced at least 1 relapse within the prior year or 2 relapses within the prior 2 years and had an EDSS score from 0 to 5.5. So a few things. Oh, and then we'll go on a little bit more. Sorry, I stopped too soon. Patients with PPMS were excluded. And so a few things here. So EDSS had to be between 0 and 5.5. So theoretically, patients that were severely disabled and had EDSSs of 6 or greater were excluded. So they wanted patients that weren't necessarily severely impacted by MS at this point in their lives. And then furthermore, they were excluded if you had primary progressive forms of MS in this particular study versus a more kind of relapsing remitting type of disease. The primary outcome of both study 1 and study 2 were annualized relapse rate, or ARR. They also did some measurements with MRI, which is standard of care. Disability progression was considered confirmed when the increase of EDSS was confirmed at a regular scheduled visit within 12 weeks of the initial documentation of neurological worsening. This is the criteria that they applied to determine whether or not somebody had progressed or not in the eyes of the investigators. Right, now when push comes to shove, this kind of goes on to summarize a lot of the data that's captured in this in this table down here, which I think is a little bit easier to understand if you go through it this way. So here, Ocrevus review, study 1, study 2. So you can see there was a one-on-one randomization almost. So each arm of these trials each had approximately 410 to 420 patients. And then you can look at the annualized relapse rate between the two groups. So this is a rate. So it's 0.156 patients per year. Or another way of looking at that is you have call it a 15% chance of having a relapse that year. And it's important, this is still normalized to every 24 weeks. So it's not every annual. And proportion relapse free, this is over the course of the entire trial, north of 80% in both patients relapse free. Interesting that the Rebif arms were also relatively relapse free. The majority of patients did not have relapses, 70% of patients. Proportion of patients with 12-week confirmed disability progression, risk reduction. So here you can see that 9.8% of patients on Ocrevus and 15.2% of patients on Rebif had progressed or worsening disability. You can find some additional information about the endpoints and how well patients performed between the two arms, in terms of their the presence of new gadolinium enhancing lesions per MRI. And we won't go through this in detail, but it appears that there's a significant reduction in underlying disease activity as measured by MRI. Here, this is an interesting plot. This is these are called Kaplan-Meier curves. I guess it's outlined here as high-level figure 1. And this is the proportion of patients having confirmed disability progression as you go from left to right. This is time. And you can see how many patients are kind of falling off here over time. And interestingly, its proportion, this only goes up to 20%, this scale. So that's one thing to keep in mind. It's actually still, even when you get to the top right-hand corner, 15.2% for your Rebif arm. You're still relatively low proportion of patients. And then 10% of patients, or 9.8% of patients, after 96 weeks have progressed. So you can see a significant reduction in the rate of progression. Here is the difference in there. Moving on, similar data here for PPMS. I'm not going to talk about this, but you can extrapolate what we just talked about here. There is some back and forth. This is the only product that's approved for PPMS on the market, so I'm not going to say kind of more about the utility of this drug because there's really just limited clinical options for these patients, unfortunately. The final thing that we'll talk about today is a safety study on 2-hour infusions. It's nice that they include the NCT numbers. If you want to go look this up, this is actually a standard number that is given by the FDA to pharma companies or anybody running clinical trials to uniquely identify their clinical trials. You can search here and go to here and here. This is a study to evaluate the effectiveness and safety of ocrelizumab in patients with early stage relapsing remitting sclerosis. And then you can get some additional data on this. It was sponsored by Hoffmann La Roche, which is the company that owns Genentech. Active, not recruiting. It first posted in 2017. It was last updated in February of 2023. And you can scroll down here for additional information about the trial as well. You can get some information about study locations, and then you get some additional information about how big the trial was. It was actually 1,239 participants, and then this is how it was, the trial was run. So you can read through this if you want to get some additional detail here. We'll fast forward because we really just, from our perspective, care what the results of the trial were. So all you need to know is that for the first dose of Ocrevus, it was the same. So for those first two half doses that were separated by 2 weeks, there's no difference between the arms. They did the exact same procedure. However, at the 6-month follow-up is where the clinical trial was split out. And so patients either got their infusion over 3.5 hours or 2 hours after the same appropriate pre-medication between both arms. So they got the methylprednisone and an antihistamine. Again, on here, the primary endpoint of the sub-study was a portion of patients with infusion reactions occurring during or within 24 hours following the randomization of infusion. So this is the first kind of 6-month dose. The primary analysis was performed when 580 patients were randomized, at which time 81% of treatments have received only one dose. Moving on, this is the key piece here is overall in all randomized doses, 27.1% of the patients in the 2-hour infusion group and 25% of the patients in the 3-hour infusion group reported mild or moderate infusion reactions. 2 infusion reactions were severe in intensity, with 1 infusion reaction reported in 1 patient in each group in the study. There were no life-threatening, fatal, or serious infusion reactions in the study. So all this is to say, comparing 27.1 into 25%, and then moving down here, 1 severe infusion reaction reported in 1 patient in each of the groups. All you need to know is, in summary, there was no difference between whether or not the patient got the drug in 2 hours or 3.5 hours. So, if your doctor is talking to you about, wanting to shorten your dosing interval, the clinical data supports there being no difference in terms of your risk for having an adverse event. Let's scroll up here. I think we've covered the meat of it. There's really an incredible amount of data in drugs prescribing information. Like I said before, use specific populations. Those are pregnant or trying to get pregnant. Those are currently breastfeeding. Pediatric use, and if there's any limitations to using the drug in patients under the age of 18, you can find more additional detailed information here. It's a wealth of information. I suggest that if you want to learn more about a drug, this is really the gold standard for kind of understanding the clinical utility here. I'll stop there for today. Thank you very much for listening to me. If you're still on watching the video, let me know if you have any suggestions for other drugs that you'd like me to discuss, and I hope to see you again soon.